Welcome to Online Anesthesia Video of the Week. Today topic is presented by Dr. P. Deepti, MD Anesthesia, working as an Associate Professor in Department of Anaesthesia, Tamil Nadu Government Multi-Super-Speciality Hospital, Chennai. She did her postgraduate in MD Anesthesia at Madras Medical College, Chennai during 2005 to 2008. Her work experiences are Senior Resident and then Assistant Professor, Anesthesiologist in Institute of Surgical Gastroenterology, Government Stanley Hospital 2009 to 2013. Senior Assistant Professor, Anesthesiologist in Madras Medical College, Government Hospital March 2013 to April 2021. Associate Professor, Anesthesiologist at Viluppuram Medical College, from May 2021 to April 2023. And presently is Associate Professor, Anesthesiologist at Tamil Nadu Government Multi-Super-Speciality Hospital, Chennai. Her field of interest are hepatobiliary pancreatic and liver transplantation anesthesia, anesthesia in vascular surgery, renal transplantation anesthesia. She has conducted and presented in following workshops: ventilatory graphics at ASACN 2009 in Chennai, hemodynamic monitoring using pulmonary artery catheter at Thursday 2009, ultrasound guided central venous catheterization October 2010 in Chennai, inter-op and post-op management of liver transplant patients at CME held in Chennai 2010. Advanced hemodynamic monitoring using Vigilio and F1000 monitors at Thursday 2012 conducted by Stanley Medical College. Management of brain dead donor, lecture at MACME 2014, conducted by Madras Medical College. Perioperative anesthetic management of liver transplant recipient, MACME 2018. As an anesthetist, she has vast experiences in liver transplant, as she has performed 33 cases of liver transplantation from January 2009 to February 2013, from pre-operative assessment to post-operative care at Institute of Surgical Gastroenterology, Government Stanley Medical College Hospital, Chennai. Anesthetized 3 cases for liver transplantation in CETHAR Hospital, Trichy, Tamil Nadu. 1 case of liver transplantation in Kamakshi Hospital, Chennai, Tamil Nadu.
Good day to all. Today's topic of mine is anesthetic challenges and liver transplantation. 1996. As per Thomas Tals, ironically, liver replacement, which was once considered the formidable of whole organ transplantation procedures, was least likely to be practical, has become the flagship of new and that are applicable to recipients of all whole organs. Now coming to the anatomy of the liver. The liver weighs around 1200 to 1400 grams. It has a dual blood supply, arterial supply from the hepatic artery and venous supply from the portal vein. It constitutes about 2.5% of the total body weight. The total hepatic blood flow is around 25% of the cardiac output. The hepatic artery supplies 25 to 30% of the hepatic blood flow, and the oxygen requirement is around 45 to 50%. The portal vein supplies 70 to 75% of hepatic blood flow, and that makes about 50 to 55% of oxygen. In liver transplantation, adequate flow through the hepatic artery is essential for viability of a new liver graft. The liver is innervated by left and right vagi, right phrenic nerve, and fibers from T7 to T10 sympathetic ganglia. Hepatic artery is innervated mainly by sympathetic fibers and hepatocytes by unmyelinated sympathetic fibers. The bile ducts are innervated by both sympathetic and parasympathetic fibers. The role of hepatic innervation is unclear, as denervation of transplanted liver does not affect its function. Now a little bit about the history of liver transplant. 1958, Francois Moore described the orthotopic liver transplantation technique in dogs. 1963, Stahls performed the first liver transplantation. The first 5 liver transplantations, no patient survived more than 23 days. In 1967, stimulated by Calne, who used anti-lymphocyte serum, Stahls began a successful series of liver transplantation. Roy Calne in 1979 used the first time cyclosporin in 2 patients who had undergone liver transplantation. In 1989, Stahls reported a series of 1,179 consecutive patients who underwent liver transplantation, and reported a survival rate between 1 and 5 years of 73% and 64% respectively. 1990, STARS reported successful use of tacrolimus in patients undergoing liver transplantation. Since 1963, when first human liver transplantation was performed by STARS, world has witnessed 60 years of development in surgical techniques, immunosuppression, organ allocation, donor selection, indications, and contraindications in liver transplantation. The liver transplantation represents the treatment of choice for end-stage liver disease. The important outcome determinant is graft quality. So there are three critical types of grafts which are used commonly. The grafts which are donated after brain death, the grafts which are donated after cardiac death, and the grafts donated by a living related donor. So irrespective of the source of the graft, the diseased liver, as we can see on the left side or the top corner, is removed from the recipient, and then the new graft is transplanted into the recipient. Now this is in a live donor where a part of his or her liver is removed from the donor and then transplanted into the recipient after the removal of the native liver in the recipient. Now there are three critical phases of liver transplant: pre-anhepatic phase, anhepatic phase, and neohepatic phase. The pre-anhepatic phase begins from the skin incision to clamping of the inferior vena cava, portal vein, and hepatic artery. This is when the liver is being dissected. Anhepatic phase is from the moment the hepatic venous inflow is being clamped up to the graft reperfusion. Neohepatic phase begins from the moment of the liver reperfusion, resumption of flow in the portal vein and IVC, complicated by post-reperfusion syndrome. Now, what are the indications for liver transplants? Non-cholestatic liver diseases, cholestatic liver diseases, malignant disease, extrahepatic biliary atresia or hypoplasia, metabolic diseases, hepatic vein thrombosis, acute hepatic failure, retransplantations. Now, there are prognostic indices, two commonly used scoring systems which assess the severity of the liver's dysfunction. One is Child-Turcotte classification, as we all know, comprises encephalopathy, ascites, bilirubin, albumin, prothrombin time. The next is MELD sodium, a better predictor of 3-month waitlist mortality and is less subjective. The sickest patients who are most likely to die awaiting liver transplant receive the highest waitlist priority. Higher waitlist priority is also given to patients with certain disease processes such as acute liver failure, primary non-function of recently transplanted liver, and hepatocellular carcinoma. Now, this original MELD score comprises creatinine, bilirubin, and INR. Now, the MELD sodium factor is added to the original MELD score to get a MELD sodium. Now, pathophysiological consequences of end-stage liver disease, which involves central nervous system involvement, encephalopathy from mild confusion to coma, brain edema which occurs in fulminant hepatitis with increased intracranial pressure, the cardiovascular system which involves hyperdynamic circulation, reduced systemic resistance, increased plasma volume, pericardial effusion. Here the cardiac output is 2 to 3 times normal, impaired systolic and diastolic function together with attenuated cardiac response to stimuli. Coronary artery disease is not uncommon. So when the patient is going to be worked up for cardiovascular system, coronaries have also to be worked up if the patient is symptomatic or had complaint of a previous history of angina. Now, portopulmonary hypertension is also involving the cardiovascular system, which is characterized by 1. A mean pulmonary artery pressure of more than 25 millimeters of mercury at rest and greater than 30 millimeters of mercury with exercise. Second, elevated pulmonary vascular resistance greater than 240 dynes per second per centimeter per fry. Third one, normal or decreased pulmonary artery wedge pressure of less than 15 millimeters of mercury. So if the right ventricular systolic pressure is more than 50 millimeters of mercury, then right heart catheterization is done to calculate the mean pulmonary artery pressure. Severe portopulmonary hypertension results in mortality if associated with right ventricular dysfunction. Now coming to the pulmonary system, pleural effusion, interstitial edema, atelectasis, ventilation perfusion mismatch, and shunting occurs. Not only this, we have a hepatopulmonary syndrome, which is a triad of liver dysfunction, hypoxemia, a PaO2 of less than 80 millimeters of mercury, or alveolar arterial gradient more than 15 millimeters in room air. Third is pulmonary vasodilatation. So intravenous bubble contrast echo is used to distinguish hepatopulmonary syndrome from intracardiac shunts. Gastrointestinal system, esophageal varices, ascites, portal hypertension, delayed gastric emptying. Hematological system, reduced clotting factor levels, anemia, thrombocytopenia, reduced clearance of fibrinolytic substance and tissue plasminogen activators. Endocrine system, glucose intolerance, diminished glycogen stores. Renal, oliguria, hepatorenal syndrome, or prerenal azotemia. Hyponatremia because of use of diuretics or increased antidiuretic hormone activity. Hypokalemia because of poor nutrition, use of diuretics, and intestinal losses. Preoperative evaluation. Anesthesia consultation is performed once a patient with end-stage liver disease is referred to the liver transplantation center. Anesthesia consultation is focused on evaluation of functional reserve of extrahepatic organs and various tests or consultations that may be requested. So it is a multidisciplinary team which is involved in this liver transplant program, which is headed by the hepatologist and role played by the anesthesiologist, cardiologist, pulmonologist, dentist, ophthalmologist, ENT, urologist, nephrologist, nutritionist, intensivist, and in female patients, gynecologist. So evaluation of potential liver transplant at the transplant unit begins with the history and physical examination, laboratory studies. Coming to the preoperative evaluation, begins with the name, age, sex, height, weight, body mass index, blood grouping typing, CTP score, and the MELD score. Blood investigations would include complete blood count, blood sugar levels, liver function test, serum electrolytes and creatinine, prothrombin time, their coagulation profiles, arterial blood gas, ammonia, lactate levels, blood grouping and cross-match, TRANSPLANT levels, brain natriuretic peptide, thyroid function test, tumor markers to rule out presence of other cancerous conditions, renal assessment. As we come to this renal assessment, I would like to make a point that serum creatinine does not reliably give us the functional assessment of the kidneys. That is because of reduced muscle mass in the recipient and also decreased production of creatine. So additional investigations like the 24-hour urine protein, urine spot sodium, urine plasma creatinine ratio, plasma osmolality, and highly sensitive tests like cystatin C or NGAL are needed for assessment of the kidneys. Because we need to differentiate whether it is hepatorenal syndrome or chronic renal failure, because the management differs. Hepatorenal syndrome responds to liver transplantation, whereas in the chronic failure, patient would need an additional renal transplant in spite of the liver transplant. So coming to radiological investigations, X-ray chest, abdominal ultrasound with Doppler, computerized tomography and magnetic resonance imaging of the abdomen, CT of the brain, 12-lead ECG, transthoracic echo, saline agitated echo to rule out hepatopulmonary syndrome, pulmonary function test, upper and lower GI endoscopies, pre-transplant infectious disease screening, and screening for viruses like Epstein-Barr virus, cytomegalovirus, herpes simplex, herpes zoster, and also for tuberculosis. Because in the post-operative period, there may be flaring up of tuberculosis once the patient is started on immunosuppressants. And as anesthetists, we would like to know about the diameter of the vessels of the neck, great vessels of the neck for insertion of maybe a 12 French or wide bore catheters, or an advanced venous access for pulmonary artery catheter, or another central vein catheter into the same IJV or into the subclavian for want of more ports for administration of fluids and drugs. So this is just a picture to show you that this is an advanced venous access which is inserted into the internal jugular vein, where a PA catheter can be introduced into it. And the subclavian has a triple lumen central venous catheter. Now, coming to cardiopulmonary evaluation, coronary angiography may be necessary if the risk factors are present for cardiovascular disease. If severe portopulmonary hypertension is present, then moderate portopulmonary hypertensions can be treated with prostanoids, endothelial 1 inhibitors, posterase diase 5 inhibitors, and those appear to reduce the perioperative risk if the mean pulmonary artery pressure can be reduced. Now, this is a cardiac scan, which gives us the coronary artery calcium, which is a marker of overall coronary atherosclerosis. So there's something called as the Agatston's score. The greater the score, the more is the cardiac risk in these recipients. Additional evaluations would include psychological assessment, substance misuse assessment, nutritional assessment, where the deficiencies need to be identified and supplemented. Now, preparation of the operation theater before shifting the patient into the theater. This is how a theater looks before the patient is shifted inside, with all the equipments which has to be ready before the patient is shifted inside. And now let us see a few of the equipments which are used in liver transplant anesthesia. This bell mount which is there is a rapid infusion system. It's a fluid monitoring system, fluid management system, which has an air embolus detector, is able to warm the fluids and blood, and also a rapid infuser. The one behind with the bottles is a fluid warmer. The one on the left side is the one used to store blood. The blood which is used is leukofiltrated and gamma irradiated. Now, the cardiac output monitors used for fluid management during liver transplant anesthesia may be a pulse contour ones or thermodilution technique involved cardiac output monitors. But then we do need some parameters which any monitor can give us for fluid management. This would be stroke volume variation, global end diastolic index, intrathoracic blood volume, or extravascular lung water index. These help us in monitoring the fluid in these patients during the surgery. Forced air warming devices are there, which is very essential for temperature maintenance during surgery. Now, cell saver has a suction apparatus at one end with anticoagulant in saline. The blood is sucked from the surgical site. It is filtered and collected in a reservoir. From there, it is saline washed, enters into the centrifuge bowl through the roller pump. It is rolled, and then the blood enters into the reinfusion bag for reinfusion into the patient when needed. Now, these are the transducers for arterial as well as central venous catheters, and for the flow track for cardiac output monitor. Now, multiple syringe infusion pumps for continuous infusion of vasopressors, inotropes, anesthetic agents. Now, this TEG or ROTEM, which gives us the viscoelastic properties of the whole blood, is essential and for the blood management strategy. The TEG has R values, K value, alpha angle, MA, etc. Whereas ROTEM has CT, CFT, alpha, MCF, and CLI. Now, when the patient is, before shifting the patient into the theater, what do? Warm the OT to 21 to 23 degrees centigrade. Anesthesia machine is checked. transducers and monitors are set, syringe infusion pumps, digi infusion pumps, stopcocks and cannulas are kept ready. Fresh soda lime is filled and new HME filters fitted. Humidified breathing circuits are fixed. Emergency cart is checklisted. Antibiotics and emergency drugs are loaded. Tegaderm, 4 eyes and bite blocks are kept ready. Warming mattresses over the OT table are switched on half an hour before shifting the patient. Rapid infusion system tubings are connected and primed. Cell saver kit is fixed, primed and kept ready for use. Ultrasound machine, defibrillator, transesophageal echoes are kept ready. Large number of labels, lab requisition forms, anesthesia records with patient's name, medical records number imprinted on them or ascertained. Patient is scrubbed with betadine from neck to toe and back. He or she is fitted with a sterile OT dress. His or her documents and consents are reviewed. Demands placed for blood and blood products are ensured. Now this is just that Belmount fluid management system in action and in use. And these yellow stickers, which has A plus, is a blood group is A positive. And the sticker, the total number of that stickers gives us the total number of units of packed cells which are used during liver transplantation. Now that liver transplants have been performed with no blood transfusion at all. Now let us begin the conduct of anesthesia. As the patient is shifted inside the theater on table, standard monitoring 5-lead ECG, NIBP, pulse oximeter, and temperature are fixed to the patient. Always and always remember to pre-oxygenate the patient. Rapid sequence induction is done because of ascites, presence of ascites, gastroparesis. The main requirement of induction is cardiovascular stability. Now coming to the anesthetic drugs effects in patient with end-stage liver disease. Induction agents, etomidate may be safely used. Propofol and thiopentone dose has to be reduced. Propofol sensitivity to sedative and cardiorespiratory depressant effect is increased. Thiopentone dose is to be reduced because of reduction in plasma proteins, increased unbound fraction of the drug. So distribution, half-life, and duration of the drug is also prolonged. Now coming to opioids, remifentanil is ideally suited because it's metabolized by the plasma and red cell esterases. Fentanyl does not have any active metabolite and renally excreted can be used. Alfentanil, elimination and protein binding is reduced, volume of distribution is increased. Morphine, yes, we try to avoid morphine. Neuromuscular blocking drugs, because of reduced pseudocholinesterase, there's reduced metabolism of scolin. Apparent resistance of neuromuscular blocking drugs occur in patients with end-stage renal disease because of increased volume of distribution and altered protein binding. So atracurium, cisatracurium would be suitable because they do not rely on hepatic excretion. Vecuronium and rocuronium, which are steroid-based neuromuscular blocking agents, have prolonged elimination phase. It's always advisable to monitor neuromuscular function because fast tracking is now the call of the day. And coming to the volatiles, isoflurane, sevoflurane, desflurane have minimal hepatic metabolism. So moreover, patients have reduced inhalational anesthetic requirements. Maintenance of anesthesia. After intubation, air-oxygen mixture is used and end-tidal carbon dioxide is monitored. Tidal volume of 6 to 8 ml per kg, avoiding high P%. Nitrous oxide is avoided to reduce cardiovascular depression, gut distension, and bubble formation if veno-venous bypass is used. Maintenance with desflurane or isoflurane with continuous infusion of fentanyl is done. Cisatracurium or atracurium infusion provides adequate relaxation and reliable reversal after prolonged use due to its organ-independent elimination. After this, arterial lines and central venous catheters have to be inserted. So a radial and a femoral artery are cannulated due to the need for frequent blood sampling from the radial artery and continuous invasive blood pressure monitoring during the long surgery from the femoral artery. Radial artery pressure monitoring may underestimate aortic pressure in hypotensive scenarios and use of vasopressors. Now, femoral artery, being the more central artery, is more reliable. Mean arterial pressure should be followed over peripheral radial systolic pressures. This is just to say that the more the central the femoral artery, the more is the mean arterial pressure when compared to a distal radial artery in all these recordings. Now, central venous catheterization could be 2 catheters into one internal jugular vein, or one catheter in one internal jugular vein and the other in subclavian, or one internal jugular vein and the other femoral vein can be used for catheterization. If advanced venous access is going to be used for pulmonary artery catheter, then preferably internal jugular vein on the right side is preferred. A core temperature using an esopharyngeal or esophageal probe is mandatory, but care should be taken while introducing nasopharyngeal temperature probes or Ryle's tube insertion because of presence of esophageal varices. Since the procedure involves IVC clamping, wide bore peripheral lines in the upper part of the body is essential. Bladder catheterization is done for urinary monitoring, output monitoring. Rapid infusion systems are then connected to the lines secured, and all the infusions are also connected. This is to show you that the femoral vein and the femoral artery have been cannulated. There is a color code which could differentiate arterial catheter from the venous catheter. So positioning of the patient during surgery is supine with right arm tucked and left arm out on armboard, abducted to a maximum of 70 degrees. A warming hot air over blanket is used. Lower chest and abdomen are exposed for surgical access. All possible pressure points should be padded, examined carefully before and after draping to reduce the possibility of pressure damage occurring. All monitoring lines and ECG leads should be positioned carefully to avoid injury, and ECG electrodes are sealed down with Tegaderm adhesive dressings. Temperature for maintenance, a second warming blanket is placed over the patient from waist to feet. All intravenous fluids are warmed. Active warming should begin immediately once the patient is anesthetized. Moreover, he lies over a mattress which has already been warmed for half an hour. Now, bispectoral index. This one is a good tool to maintain the anesthetic depth. Moreover, in patient with fulminant hepatitis where there is an hepatic grade 3 or grade 4 hepatic encephalopathy, the suppression ratio is increased and your BIS is almost towards a single digit. But after the graft has been transplanted and it starts functioning, slowly the BIS improves, which serves as a prognostic indicator to tell us that the graft is functioning. Now, this is a cerebral oximetry monitor, which gives us the values of the left and the right cerebral hemisphere. Now, once the lines have also been set, the blood samplings have to be repeated frequently. Coming to the TEG or ROTEM, ABG analysis, electrolytes, blood glucose, and hemoglobins, how often are they done? So as soon as the lines are inserted, a baseline value of all these are taken. Once into pre-anhepatic phase, these investigations are done hourly. Before 15 minutes before anhepatic phase, they are repeated. Into anhepatic phase, 1 hour into anhepatic phase, they are repeated. Before reperfusion, 5 minutes before reperfusion, investigations are repeated. And after that, 15 minutes after reperfusion, again they are sent for reports. Half hourly after reperfusion in the OT, and then post-operative in the liver ICU, it's 4th or 6th hourly. Intraoperative anesthetic techniques. So it's convenient to us to divide this into 3 critical phases as we have already seen: pre-anhepatic, anhepatic, and deohepatic. Now let us see these critical phases in detail. Starting with pre-anhepatic phase, the surgical details of it begins from the start of the incision, which is an inverse T-shaped or extended bilateral subcostal incision. During this phase, mobilization of structures around the liver and porta hepatis are done. Hepatic artery and bile duct are divided. Portal vein, suprahepatic and infrahepatic IVCs, or the hepatic vein, when a piggyback technique is used, is clamped. And this here, clamping of this venous inflow ends the pre-anhepatic phase. And then the anhepatic phase begins. Now, what are the anesthetic considerations during this phase? Hemorrhage from dissection, varices, and adhesions takes place. Cardiovascular instability occurs from ascites decompression, low systemic vascular resistance, and causes hypotension. Overtreatment with fluids, blood components causes Planck condition and exacerbates bleeding. So this is the incision for liver transplantation surgery, as I mentioned before. So what do we do during this phase? Maintain a low CVP, which can represent an option for reducing bleeding. Hyponatremia, slow correction of it, of around 8 to 12 milliequivalents per liter in 24 hours can be done. Potassium to be maintained below 4 milliequivalents per liter with the use of calcium, bicarbonates, insulin. Use of point-of-care devices for transfusion guidance like TEG or ROTAM is a must. The volume status is to be optimized to be achieving a balance between fluid perfusion and vasopressors, but alpha-adrenergic agents to be avoided because those cause reduced renal and peripheral perfusion. Now coming to this fluid management, there is no ideal crystalloid solution and all of them have their own limitations. Excessive use of normal saline can cause hyperchloremic acidosis, while lactate in the lingual lactates require liver metabolism for its elimination. Plasma light has a pH near normal and electrolyte and osmolarity similar to plasma, but it is pro-inflammatory and potentially cardiotoxic. Use of colloids over crystalloids is not supported with convincing evidence. Albumin 20% yes can be used due to the fact that these patients are hypoalbuminemic and it helps in increasing the oncotic pressures too. Intravascular volume is usually replenished during this phase by administration of a mixture of packed red cells, FFP, and plasma-light A in the ratio of 300 ml is to 200 ml is to 250 ml respectively using a rapid infusion device. And why is this done so? This mixture yields a hematocrit of around 26 to 28 volumes percent and a coagulation factor levels of 30 to 50% of normal. A low hematocrit is chosen to optimize microcirculation and prevent hepatic artery thrombosis because once the viscosity increases, yes, they are prone for it. Intraoperative cell salvage is strongly advocated. Now, this fluid management can be based on the parameters like stroke volume variation. A stroke volume variation of more than 15% will tell you that the patient is slightly dry and fluid responsive. So the cardiac output monitors like your EV1000, LITCO, PICO, any of these would give us the stroke volume variation, cardiac index, your central venous oxygen saturation, systemic vascular resistance or systemic vascular resistance index, based on which fluid management can be decided on. Transesophageal echo is one of the greatest strengths, which has its ability to directly visualize in real time the preload of both right and left side of the heart, which helps in fluid management. It also accurately determines the stroke volume and left ventricular changes. Intraoperative TEE allows for real-time detection of myocardial ischemia manifested by regional wall motion abnormalities. It's also a very sensitive monitor for detection of air embolism. Now the anhepatic phase. Anhepatic phase has already been started during the clamping of the vascular structures. Now the surgical details involves portal vein and hepatic veins which are divided, explantation of the native liver, IVC preparation for implantation, the new liver is inserted and the caval and portal anastomosis are fashioned. So this is a stage where there is no liver function. So anesthetic considerations would involve no production of clotting factors, fibrinogen deficiency, worsening of coagulopathy, progressive hypocalcemia, absent citrate and lactate metabolism, reduced gluconeogenesis, increasing serum lactate, worsening metabolic acidosis, and persistent surgical hemorrhage. So this is a phase of surgery where patient is anhepatic, total loss of liver function. Patient becomes acidotic, hypocalcemic, hyperkalemic, worsening of hyperkalemia in spite of treatment with sodium bicarbonate, calcium, insulin, etc. may require intraoperative renal replacement therapy. Due to clamping of IVC, fluid resuscitation in this phase should be carefully considered and guided by hemodynamic data. Excess fluid can result in fluid overload during reperfusion, which could lead to volume overload, right heart failure, and graft congestion. It has been recommended that adequate arterial pressure is maintained with the help of vasopressors and inotropes. So noradrenaline, adrenaline, dopamine are all used of choice during liver transplant anesthesia. Ionized hypomagnesemia occurs. Hypophosphatemia causes thrombocyte dysfunction, disturbance in myocardial contractility, and neuromuscular irritability. And replacement in the form of potassium phosphate preparations can be done, but then again, hyperkalemia should be kept in mind. Use of TEG or ROTEM for targeted management of coagulopathy has now formed the guidelines for management of massive bleeding. Platelets, intraoperative platelet transfusion have been identified as a strong independent risk factor for survival after liver transplantation. Antifibrinolytics, the guidelines say it is recommended to consider administration of antifibrinolytic drugs when fibrinolysis is confirmed in TEG or ROTEM and not clinically evident for microvascular oozing and not as a routine practice. The use of recombinant factor A, the guidelines recommend against the prophylactic use of recombinant factor A during liver transplant, reserving its use only as a rescue therapy for massive hemorrhage. During this phase, corticosteroid therapy is started intraoperatively with a bolus dose of methylprednisolone 10 to 15 milligram per kg. Hyperglycemia needs to be monitored regularly during this procedure and treated. Recipients with hepatitis B receiving hepatitis B negative graft should be infused with hepatitis B hyperimmunoglobulin. So it is not only the anhepatic phase which is being treated here, but then we are preparing for the next neohepatic phase. So this neohepatic phase, the surgical details include graft reperfusion. Once the hemodynamics stabilize after the reperfusion, hepatic artery is anastomosed, biliary reconstruction is done, hemostasis is secured, the graft function is assessed, and then closure of abdomen in the layers begins. So coming to anesthetic consideration, the graft reperfusion causes hypotension, further decrease in systemic vascular resistance. Sudden preload increases at reperfusion. Abrupt potassium increase at reperfusion with possible cardiac arrhythmias or cardiac arrest can occur. So the post-reperfusion syndrome is defined as 30% decrease in mean arterial pressure for at least a minute within the first 5 minutes of graft reperfusion. It can have fatal consequences from arrhythmias to asystole. So preventive actions before this graft reperfusion, all this while during the anhepatic phase, I think we have been doing all that, normalizing our blood gases, normalizing the temperature, normalizing electrolytes like calcium, potassium, using inotropes and vasopressors to maintain circulatory support. Cell saver usage helps in prevention of increase in potassium levels due to massive transfusions. FiO2 during this phase is to be maintained at 100% in order to increase the oxygen stores, and inhalation agent should be decreased to minimize vasodilatation. Now, primary non-function or delayed function of the graft is indicated by ongoing metabolic acidosis, coagulopathy, and absence of bile production. So once we have overcome this post-reperfusion syndrome, the hepatic artery is anastomosed, biliary reconstruction is done, and then abdomen is closed in layers after hemostasis is secured. Now, towards the end of it, fast tracking of liver transplant patients have to be considered, but based on the patients. Every patient behaves in a different way. Coming to fast tracking of liver transplant patients, the potential advantages include improved early graft blood flow due to the absence of positive pressure ventilation. So we as anesthetists would take a call on this. It not only reduces the pulmonary complications and improves the graft function, but also causes reduced ICU stay and decreased incidence of nosocomial infections. Now, when you've decided to post-operatively ventilate the patient, it's wise enough to shift or wheel in the ICU bed, which has a weighing scale, into the OT, transfer the patient from the OT table directly to the ICU bed, and then wheel out the patient from the operation theater, making sure that all the infusions, IV fluids, monitoring, ventilation through a transport ventilator is continued. Patient is wheeled out of the OT into the ICU safely. Now this, I was mentioning about this ICU bed with a weighing scale. The immediate post-operative weight gain is associated with graft failure, early allograft dysfunction, and overall mortality. So this bed with a weighing scale helps in monitoring the weight of the patient every day. Now, immediate post-operatively, when the patient is shifted, head of the bed is raised to 30 to 45 degree. Pseudoanalgesia can be discontinued early depending on the patient's condition. Analgesia can be a bolus dose of opioids, or in case continuous infusion is needed, yes. Invasive cardiovascular monitoring and careful fluid management is continued. Vigilant monitoring for bleeding and coagulation is also done. Your arterial blood pressure, ECG, standard monitoring with the CVP, body temperature are continuously monitored, and urine output is checked hourly. Active warming is continued. After checking for vital functions, all the drains, catheters should be emptied, recorded, and then a fresh monitoring started. 12-lead ECG and chest X-ray are performed in all patients and are repeated as required. As already discussed, the laboratory workup is repeated every 6 to 12 hours, depending on the condition of the patient. The samples for cultures of blood, urine, tracheal secretions are all obtained as required, according to the institution's protocol. Following initiation of immunosuppressive treatment, the therapeutic monitoring of the immunosuppressants is performed and adjustments are made as necessary. Now, blood flow in the hepatic artery and portal vein should be examined every day, and certain institutes have their own protocols for the blood flow Doppler ultrasonography, especially during the first 3 days, and it should be repeated as and when required. And what are the common complications after liver transplantation? The early complications would be bleeding, primary allograft dysfunction, primary allograft non-function, thrombosis of the portal vein, IVC and hepatic vein thrombosis, biliary tree obstruction, hepatic artery thrombosis, acute kidney injury which might need renal replacement therapy, sepsis, cardiovascular events. Late complications would include immunosuppressant-related side effects, infection, graft rejection, recurrent primary disease, biliary tree obstruction. So vigilance is always needed till the patient is extubated and then shifted out of the ICU. So these are the references. Now, the take-home message would be a saying by Franklin D. Roosevelt. The only limit to our realization of tomorrow will be our doubts of today. Our doubts and fears can limit our potential for future success. This quote conveys the importance of overcoming self-doubts and having belief in our ability to achieve great things. So best wishes to all, and thank you.